Welcome to Bear in Mind, the Brown Psychiatry Podcast, clear, current content about mental health. I am the host, Dr. Tracey Guthrie, Psychiatry Residency Program Director and Co-Editor-in-Chief.
I'm the co-host, Dr. Camila Cosmo, Brown Assistant Professor and Co-Editor-in-Chief.
And I'm Steve Rasmussen, the guest. I am the Professor of Psychiatry and Human Behavior at Brown and the Chair of the Department of Psychiatry and Human Behavior at Brown.
First, a content warning.
In this episode, we will talk about sensitive topics, some of which you may find triggering. Our only purpose is to provide education and information. Our content is not to be considered medical advice. Imagine if your mind got stuck on a thought, a worry, or an image, and no matter how hard you tried, you couldn't shake it off. Imagine feeling compelled to repeat certain actions over and over again, like washing your hands, checking locks, or counting, even though you know it might not make much sense. That's what every minute of the day can feel like for individuals with Obsessive-Compulsive Disorder, or OCD.
OCD is a common mental health condition that affects people of all ages and backgrounds, and it involves a cycle of distressing thoughts known as obsessions, which often trigger a strong urge to perform repetitive behaviors, also called compulsions. These obsessions and compulsions can greatly impact daily life, relationships, and overall well-being, but there is hope.
With understanding, support, and effective treatments, individuals with OCD can learn to manage their symptoms and lead fulfilling lives.
To help us discuss this critical topic, we are delighted to have Dr. Stephen Rasmussen with us today. His work has greatly enhanced our understanding of OCD and impacted the treatment approach. He has also served as the chair of our Department of Psychiatry and Human Behavior at Brown, and it's our pleasure to have you here today, Dr. Rasmussen. Welcome.
Thank you very much, Camila. I'm looking forward to trying to tell people about my 40-year experience with treating patients with obsessive-compulsive disorder.
Wonderful.
So, Dr. Rasmussen, what is OCD and how does it differ from everyday worries?
So everyone can relate to what it's like to worry about something. We all have worries about our jobs, about our personal lives. But patients with OCD worry about things that sometimes don't make sense. And that distinguishes it from other types of worries, which all of us have and make sense to us because they seem real. Right. For patients with OCD, what happens is that you start to worry about things that most people think would never happen. But it's a potentially catastrophic sort of thing that could happen. So, for example, you might cause someone to get sick and die if you spread germs, or you might leave the stove on because you haven't checked it carefully enough, and therefore the house will burn down and someone will die. So people begin to worry about things that most of us don't worry about. When we go to lock our doors, most of us lock it and don't give it a second thought. People who have obsessive-compulsive disorder think about what could happen in a way that most of us don't.
Mm-hmm. Mm-hmm. And how does OCD impact a person's daily life, relationships, and their overall well-being?
So, like anxiety, obsessions and compulsions actually occur in most people. But in most people, a thought comes and it goes, and they don't pay any attention to it. But for the 2% of the population that have OCD that needs to be treated, for them, it can become a very serious problem. And in fact, for those patients who we see who have severe OCD, it's devastating and can be just as problematic as things like schizophrenia or bipolar disorder. It affects relationships, it affects families, it affects patients' daily lives. Although one of the things that is true about OCD is many people can work only to come home and have to do 4 or 5 hours of rituals at night. So it is definitely on a continuum or a dimension. Those people spending 1 to 3 hours a day with rituals are usually the people who we see as having a clinical problem. And for them, it does interfere with their social and occupational function.
And so what causes OCD, Dr. Rasmussen?
I wish we knew. That having been said, I think we like to think of obsessive-compulsive disorder as other types of medical illnesses like hypertension or diabetes, in the sense that they tend to run in families. They're made worse by stress. They're made better by some things like exercise. So they have a genetic and biologic basis. The cause of it, although unknown, we believe that there are abnormalities in the way that neurons and circuits in the brain are functioning in patients with OCD versus those that don't have it. When we do special imaging tests and compare people with obsessive-compulsive disorder versus controls, what we see are there are particular areas of the brain that light up that have to do with anxiety and obsessions and compulsions that differentiate them from people who don't have the disorder.
How do we treat OCD, and how effective are those treatments?
So when I first got started in this, Camila, maybe 40 years ago, the treatment was really psychodynamic psychotherapy. And we've really made significant progress in our ability to treat patients with obsessive-compulsive disorder over the last 4 decades. There are two mainstay treatments. One is pharmacologic, or a drug treatment, which is a type of antidepressant that works on a chemical in the brain called serotonin. The other way that we can treat obsessive-compulsive disorder is a psychological treatment, something called exposure with response prevention. If you think about OCD in some ways as being like a simple fear of elevators or a simple fear of flying, what makes OCD different is that the thing that causes the anxiety is everywhere in the environment. But the treatment called exposure with response prevention is somewhat the same. So the idea is for the people who are afraid of contaminants or germs, for example, that other people are not afraid of, they have to touch things that make them anxious and not wash their hands. For people who have to check things over and over, they have to lock the door once or turn the gas stove off once and then leave the house. This, of course, makes them very anxious. But what they find is that over time, if they persist in only checking once or only washing once, that their symptoms will begin to diminish. So those are the two major types of treatments that are available today, and they help probably close to 80% of the people who have OCD. Doesn't cure it. Just like high blood pressure, when you take a high blood pressure pill, it doesn't necessarily bring it back totally to normal. But it makes it so that it doesn't interfere with their function as much. And so we can now help about 80% of people with these treatments, and there are other things that are out there that are in the process of being developed, like transcranial magnetic stimulation, which is a new treatment that's been FDA approved for depression and has now recently been approved for OCD, and deep brain stimulation for the people who are really severely ill and for which no other treatments work.
Just a follow-up question. From those medications that you mentioned, which ones are the most effective and most studied?
So we know through a series of studies that we've done that not all antidepressants work for obsessive-compulsive disorder. It appears as if those that interfere with this particular chemical called serotonin in the brain are the most effective. And fortunately, there are many of these compounds that are currently available. Things like Prozac or Zoloft or Effexor or Lexapro, and are widely available from your own primary care physicians as well as mental health professionals.
So you mentioned that, we've come far in the 40 years that we can treat about 80% of people with OCD. Let's talk a little bit more about that treatment-resistant group, that other 20%. Could you speak a little bit more about what treatment options are available for them?
So right now there's been significant interest in trying to identify how the connections between nerve cells, which we call circuits, work in psychiatric disorders. And there have been a variety of treatments that have become available designed to try to affect the abnormalities in the circuits that we see in psychiatric conditions. Mm-hmm. One of these is transcranial magnetic stimulation, which really is a magnetic pulse that is transmitted multiple times at a very low intensity across the skull and into the circuits of the brain that resets the abnormalities in the circuits that might exist. Mm-hmm. There is a lot of work currently being done on the development of new approaches to transcranial magnetic stimulation in OCD. And probably over the next 5 years, these new treatments will become available. Deep brain stimulation is another thing we've worked on here at Brown. And actually, we were the first in the country to really develop approaches for altering circuits in severely ill patients who failed to respond to all other forms of treatment.
Mm-hmm. And what are some common misconceptions and myths about OCD?
So I think that when I first got started in this, OCD was thought to be a rare condition. Mm-hmm. And we now know that it is present in 2% of the population in a severe enough form to cause significant social and occupational impairment. So I think that we, as an example, went on 2020 in 1985 with some patients from our clinic, and we got 20,000 calls after that from people saying, "Oh my God, you mean someone has this, I have this, and you mean there's a treatment for it?" So one of the myths that's out there is that it's not treatable. Mm-hmm. Another myth that's out there is that it only occurs in severe forms, mm-hmm. and I'm probably not as severe as some other people. So access is a really important thing. We know, for example, that only even now a very small percentage of people who have this illness actually come to see us for treatment. Mm-hmm. And we think that's because people don't recognize that they have this illness, and also that they don't realize that there are effective treatments for it. Mm-hmm. So one of the things that I really think this kind of show is important is to get the message out that, yes, this is a disorder that has effective treatments, and that you can come and make a big difference in your life if you're engaged in treatment.
So if someone is listening to this and thinks that they recognize these symptoms in themselves or in a loved one, what are the next steps they should take to seek help and to get diagnosed?
Well, one thing, since everybody has a smartphone phone these days, is to Google the International Obsessive-Compulsive Foundation. Mm-hmm. There they will find a huge amount of things that will be valuable to them in how to access treatment. They have a list of providers who have expertise at OCD. They have lots of videos so that you can be able to see how other people have found help. Mm-hmm. And so that would be one thing I would recommend taking a look at. Also, you can clearly call one of your local providers. You can go to your PCP. Most of the PCPs are familiar with this disorder now and can make a referral to one of the clinics, either at Lifespan or Care New England, that have expertise in this condition.
And how can family and friends best support a loved one that was diagnosed with OCD? Are there any specific do's and don'ts?
So one of the things that we have learned through the course of 40 years is that OCD usually occurs in families. So oftentimes the family members are drawn into doing the rituals for the patient. And so, for example, the patient will ask a family member, oh, please don't touch that, or wash that, or in more extreme cases, people, for example, having to change their clothes when they come into the house, or not touch things in one area of the house. Or they might find that the patient is asking them to check things for them. We know that actually working to try to reduce the number of rituals is a shared goal in treatment between families and the patient. So, but this really takes professional advice, because we also have family members who've come in who essentially said, we're not doing any of these rituals, which has led to lots of conflict that sometimes is not helpful for the patient going forward. The other thing that families can do is become more aware of what the symptoms are. The fact that this is a illness like diabetes or high blood pressure, something that they shouldn't feel stigma about. They shouldn't feel is something that's any different than those other medical disorders. And reading up on that and making certain that their loved ones seek treatment, of course, is important.
Does OCD look different in kids and adolescents?
So we know that the average age of onset for this disorder is somewhat like schizophrenia. It's around 18. But it has two peaks of when it occurs. One earlier in childhood, from 6 to 12, and then another peak around puberty, and then around the time that people might be leaving their family of origin. So the presentation, however, of what OCD looks like is quite the same between children and adolescents and adults. So those major types of symptoms, things like being concerned about dirt and germs and having to wash your hands, checking things. So they might be checking their school locker rather than the front door or the gas being turned off. But the checking aspect of it remains the same. Having to do things a certain number of times or in different patterns. Worries about that they might develop a serious illness of one sort or another, and having to ask over and over, do you think this is okay? Or things where they have to have things lined up or straightened that might make it difficult for them to finish tasks, particularly school-related tasks. They might have trouble because they have to read something over and over to make certain that they comprehend it, or they might have difficulty in being able to start and finish a written project that they have. So although the symptoms are somewhat similar, the context may change slightly.
And are there different types of OCD, and what are the most common ones?
So the most common type of OCD is fears of contamination associated with cleaning or washing rituals. And there are many, many different types of contamination. So the most common one being dirt or germs, fear of bodily fluids, so being contaminated with urine or feces or saliva. But people have fears about heavy metals. People have fears about asbestos. So the other major thing is checking. And as we've already talked about, people can check lots of different things depending on what's most valuable to them. But the most common sorts of things are things like electrical appliances or gas stoves or locks, doors, windows. People have the urge to check these things. So oftentimes we see people who have broken the lock because they've checked it so often, or have snapped off the. We used to have cars where there were roll-up windows, and they would snap off the roll-up windows. People who have what we call somatic obsessions. So these are people who are worried they have a serious illness like cancer. And so they might check their body over and over again. And then patients who need things, what we call the need for symmetry and precision. The person who has to have their hair parted exactly down the middle. Or the person who has to have his shoes tied to exactly the same tension on both sides. And they can't go on to do the next motor action until it's absolutely perfect.
Right.
So those are some of the more common examples.
We were talking about types of OCD. I wonder if there are other types of OCD that we need to let our listeners know about.
Yes, so one subtype that perhaps I neglected to mention previously were patients who have what are called taboo obsessions. And these are patients who have fears that they're going to commit some type of violent act or some type of inappropriate sexual act or do something against God. Examples would be the postpartum mother who comes in who is diagnosed as having depression. But then when you ask what she's worried about, she'll say, "Oh, I've been thinking that I might want to harm my baby, even though I know that's a terrible thought to have. I know that I shouldn't be having that thought." And that's an obsessional thought. These types of patients, for example, hide all the sharp objects in their house, and they avoid contact with their infant sometimes, which is something, of course, which they don't want to do.
Right.
So these types of taboo obsessions are oftentimes things that people are reluctant to talk about because they really feel as if there's something terrible about them,
right.
Rather than understanding that it's a fear of a thought.
So these very secretive and concerning thoughts, they can certainly alarm the person, make them more anxious, alarm family if they know. But how often do people even act on these thoughts that they have? How often does that actually happen? So
I've been working in this area for 40 years, and I've never seen someone with OCD act on the thought that they're having.
Right.
It's actually only a fear of a thought,
right?
And it's the thing that they least want to do.
Right. So the most concerning thing is really the distress that person is having that thought that we need to sort of address.
Correct.
Yeah. Is there any connection between OCD and other mental health disorders?
So there's definitely a connection with other types of anxiety disorders and other things called obsessive-compulsive spectrum disorders. This has actually been a controversy among experts in the field of whether or not it belongs with the anxiety disorders or whether it belongs with these other disorders of compulsions like pulling your hair excessively or like picking scabs obsessively or something called Tourette's syndrome, which is where you have excessive jerks or motor tics that might occur associated with it. There's some evidence that it belongs to both. And so I think that there definitely is a lot of comorbidity. There's definitely a lot of association of obsessive-compulsive with other disorders. So we know, for example, that 20% of patients with schizophrenia have significant obsessions and compulsions. 15% of patients with bipolar disorder have significant obsessions and compulsions. probably upwards of 30 to 40% of people who have anorexia nervosa or eating disorder have obsessive-compulsive disorder. And about 60 to 70% of people with obsessive-compulsive disorder are also suffering depression when they come to see us.
Right.
And other anxiety disorders are oftentimes seen. So these disorders tend to go together.
So we know that some people, they do have some habits like having a specific position when they are drinking their coffee or checking their car. And sometimes they wonder, oh, did I lock that? How can we differentiate those habits from OCD?
So I think that obsessive-compulsive behavior, because of the fact that it's now something that has actually come out in the media, it's been in movies, people are starting to say everything is obsessive-compulsive. But what really differentiates these simple habits, which all of us have, from obsessive-compulsive disorder is the amount of time that you spend on them. So most people who come to see us, to meet the diagnostic criteria for the disorder, you have to be doing 1 to 3 hours of rituals per day. It has to significantly interfere with your social or occupational function. And you have to have a lot of anxiety or distress associated with the thoughts.
And what about hoarding? For a long time, I wonder if you could talk about hoarding and how it is different from OCD and how we're thinking about that now in the field.
Yeah, so for many years, hoarding was thought to be very closely connected with OCD. And part of that had to do with the fact that people who have hoarding tend to accumulate things in a somewhat ritualistic way.
Yeah.
That having been said, we now know that the neurobiology of this disorder is different than obsessive-compulsive disorder, even though it can very seriously affect people. There are not real good treatments available for it.
Right.
So that's one of the things that differentiates it from obsessive-compulsive disorder. But it can be a major problem for both families and patients who have it, whose houses are filled with useless objects and who are unable to throw them away.
Exactly. What about research studies? Are there things happening that people can get involved with? Are there studies that are recruiting now that people can get involved with and seek help or participate in furthering the knowledge of how we treat OCD?
So we are a site here at Brown that actually has lots of research going on in obsessive-compulsive disorder, both in adults as well as in children and adolescents. One particularly, I think, important study that's going on currently is in the Bradley Hospital Center for Pediatric Anxiety and OCD, where they have a large study trying to make exposure with response prevention more accessible to a broader group of people, regardless of the insurance they have, and to try to get it out into our community health centers in a way that has not been possible before. We also have studies trying to understand what causes OCD. So many of these things are done in collaboration with researchers on campus, which are great to get people involved in because it will help us help others. And in addition to that, we do have treatment studies that are ongoing for patients with severe OCD. And we're about to open up a study looking at transcranial magnetic stimulation in OCD for those who may not have responded to drug but don't have that severe illness.
And one of our goals with this podcast is to share information and also provide resource. Do you have any additional recommendations of local and national resource for our listeners?
People should be looking at the International OCD Foundation website, which has many different types of resources that are available. Here at Butler, we have an intensive outpatient program for patients who want to get engaged in exposure with response prevention. That type of treatment is also available at Bradley Hospital for children and adolescents. So for the adult side, the OCD clinic at Butler Hospital, and for the child and adolescent side, the OCD and anxiety clinic at Bradley Hospital are two of the best resources.
Excellent. Thank you.
So thank you very much, Dr. Rasmussen, for those resources. We'll link things down below about the resources that you mentioned and the studies that are available for people to consider participating in.
Thank you so much. It was great to have you here. Now, a take-home message to bear in mind.
OCD is a mental health condition characterized by intrusive and distressing thoughts known as obsessions, coupled with repetitive behaviors, rituals called compulsions. These compulsions are often performed to alleviate the anxiety triggered by the obsessions, even though they may seem irrational.
Seeking professional help early can make a significant difference in managing OCD. We have effective treatments and strategies available, as we talked here today. Check out our website for a list of resources.
We hope you finished today's podcast with a better understanding of OCD to help you or your loved ones access earlier diagnosis and treatment. With consistent treatment from qualified mental health professionals, the quality of life and prognosis for those with this diagnosis is greatly improved. And as always, if you or someone you know is feeling depressed and having suicidal thoughts, please contact the Suicide Crisis Lifeline. Call or text 988 or access 988lifeline.org.
Thank you for listening to our podcast. For more information related content, please check our Instagram, X, Facebook, and YouTube channels. Bear in mind the Brown Psychiatry podcast. Thank you.